Thank you, everyone. It is now 20 minutes after the hour, and we will reconvene the meeting to begin oral public comment. I'll apologize for the background noise. At the start of our public comment session, I'd like to welcome and thank our public comment speakers for addressing the committee today. All of the speakers submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and in order to make it through all the listed speakers, it's extremely important each speaker limits his, her, or their remarks to 3 minutes. There's a timer displayed on the screen so you know how much time you have left. As a gentle reminder, our committee appreciates diverse viewpoints that are respectful in nature and focus on the issues being discussed today at our meeting. We thank our speakers again, and we look forward to your comments. And give me one moment to pull up the speaker list. Thank you. Our first speaker today is Elizabeth Fashing.
Thank you. My name is Elizabeth Fashing, and I am a parent to 2 children, one 9 and one just recently turned 5. And I'm asking the committee today to please do not delay consideration of the booster availability to children under 12. Our whole family did get COVID this past April, and 3 of us were fully vaccinated, but unfortunately my 4-year-old had to suffer the consequences of getting COVID without the benefit of vaccine protection. And he was the sickest among us. He had gastrointestinal issues and a high fever for a week, and I do not think that it was fair for him to have to suffer from this disease without the benefit of vaccine protection because of the delay in approving the vaccine for the under 5 population. And he is just now going to be fully vaccinated in about a week because we just started the Pfizer series on him a couple of months ago as soon as it became available to his age group. I'm not a medical professional. I'm not a research scientist. I understand that there are special liability issues and considerations for studying medications in young children, but those cautions cannot be to the detriment of getting children access to life-saving vaccines. There is going to be another pandemic, and it could very well be more deadly to children. And we cannot delay them care due to overcaution. So I would like to ask that the administration of medical and vaccine trials be revamped to ensure that our most vulnerable are included from the beginning in trials. Thank you.
Thank you very much for your comments. Next, we will move to Dorrit Rice.
Thank you. My name is Dorrit Rice. I'm a professor of law at the University of California, Hastings College of the Law. Thank you again for the opportunity to comment and for your thorough, careful work. I have 4 points to make. First, I'm concerned about the process for bringing the BA4 and BA5 boosters forward. FDA's VRBAC committee discussed this with very little data and no human trials and has not been reconvened, and there's still no direct human data. I think something like this needs more transparency at open deliberation, and I am grateful to ACIP for giving such a thorough deliberation of the data and where it stands, but it would have been nice to have it earlier. I realize we have no other mitigation measures in place, that hundreds are dying every day, and there is real pressure to act. And it's exactly at this time that expert agencies need to act to maintain confidence, and cutting processes does not help. If lack of transparency decreases usage, where is the benefit? I also understand that ACIP needs to respond to what it has, and your suggested recommendation help with clarity and do address all ages, which is good, but the process is concerning. Second, I've heard from colleagues in the medical field that there's substantial confusion as to when people should give boosters, including the new boosters, after a recent infection. Guidance from ACIP on the timing of boosters after reinfection would be really, really helpful in relation to the new one. Third, I want to remind everyone that, as Dr. Shima Bukuru set out for us in detail, the vaccines we currently use in the United States, the Pfizer, Moderna, and Novavax, have an extremely strong safety record. They're not risk-free, but the risks are small, and by and large, those seeking to deter others from vaccinating have to resort to misleading tactics like misrepresenting VAERS report, misrepresenting non-causal report from the trial data, and attributing every death and harm to vaccine with no evidence or against the evidence. We could wish the vaccines were more effective against infection, but they're safe and they prevent hospitalization and death, as again described here. The extensive misinformation campaign about the vaccine led to many unnecessary deaths and harm, and is built on a tower of lies. And finally, I would like to ask again that the hardworking and dedicated ACIP staff put up the topic for an emergency meeting when you announce the emergency meeting. I think it will help people decide whether to request to comment and help them tailor comments before the agenda is up. And adding a line like September emergency meeting, bivalent boosters would not be that much additional work. I know the staff has worked really hard over the last few years. Thank you for your work, and thanks for the opportunity to comment.
Thank you for your comment. Next, we have Ms. Patricia Neuschwander.
I've been a nurse for over 28 years and have given public comment several times to this committee, but this one takes the cake. Let me start with the absurdity that you are asking for public comments before you present the data being used to evaluate the safety or efficacy of these products. The fact that this committee is meeting today to consider recommending products that have not gone through any human trials, you have gone from junk science to no science. The FDA granted emergency use authorization yesterday without convening for the VRBAC committee to provide any expert opinion. It's absurd. Are you really going to use data extrapolated from different unnamed bivalent experimental products or mouse studies to recommend these products to millions of Americans? You consider this rigorous science? Absurd. The study using the extrapolated bivalent Pfizer product, not the product you're here for today, had 600 adults aged 55 or older, yet authorization is given for 12-year-olds and older. Absurd. After 1 month using a rapidly waning product, the immune response of the participants who received the new bivalent vaccine was better. What immune response data? No data on better protection from infection, transmission, hospitalization, or death? Just better antibody production, which I will remind this committee has not been shown in randomized clinical studies to mean better protection. It's absurd. The FDA says the safety data accumulated from the other experimental products is relevant to these products because, quote, they are manufactured using the same process. So any product that uses the same manufacturing process is deemed automatically safe? Absurd. Use of these products will require unvaccinated people to take 2 doses of the old vaccine with the original strain that's been long gone before being eligible to take the new boosters. It's absurd. The FDA said the booster you receive does not need to be from the same manufacturer as your primary vaccination or previous booster. Where are the clinical trials? It's absurd. Providers should offer all vaccines for which a person is eligible for with this experimental product without any clinical trials. Absurd. If recommended, the new booster, by the way, 4th or 5th dose, if you're keeping score, with no long-term safety, will become the CDC's definition of up to date. This will impact millions of people's ability to maintain employment, attend school, go to college, or participate in any activity that has a requirement on being, quote, fully vaccinated. It's absurd. You have the opportunity to do the ethical, morally right thing today. Healthcare providers blindly trust you. The data is not there and you know it. Do not return us to unethical human experimentation. Put an end to this absurdity and require rigorous large-scale clinical trials before you put your name on these products. Or you can choose to look the other way and potentially put millions of people in grave danger of harm. Please do your job.
Next, thank you for your comment. Next, we'll move on to Mrs. Mary Mahoney.
Good afternoon. My name is Mary Mahoney, and I am speaking on behalf of myself and my family. I want to start by thanking this committee for your ongoing commitment to ensuring Americans have access to safe and effective protections against this devastating virus. As COVID-19 continues to evolve, I am encouraged to see how the science continues to evolve along with it. When the vaccines were initially approved and made available, each member of my family was eager to receive our dose. The vaccine has provided us with the protection we were desperately needing in order to return to so many meaningful aspects of our lives that had been on hold, such as going to school, attending church, and being around the older adults that we love. When the booster shots were approved and recommended, we were just as eager to follow the guidance of this committee and our physicians in adding as much needed layer of protection. We now find ourselves once again looking to this advisory committee and the CDC for clear and straightforward guidance. on who should receive the newly approved bivalent booster doses and when. As my children head back to school and we're all head back into another flu and pneumonia season, we are eager to gain access to the best protection available to ensure a strong immunity as possible against COVID-19. I urge this committee to provide clear guidance on the use of the new bivalent booster shots, and that every eligible American understands how and when to take this next step in protecting ourselves and our families. Thank you for your time.
Thank you for your comment. Next, we have Megan Rapp.
Hi, can you hear me?
We can, thank you. Please go ahead.
Good afternoon. My name is Megan Rapp. I speak today to enthusiastically endorse boosters as a tool in preventing the spread of COVID and protecting against severe disease. I speak to say thank you for the work you are doing to make bivalent boosters available to people 12 plus. I also speak today on behalf of my 1.5-year-old daughter, Caroline, because Caroline is really too little to speak, though she can say, all done. She is also too little to follow the CDC's guidance on personal responsibility around COVID mitigation, such as assessing risk, wearing a mask, getting therapeutics, or accessing boosters. I speak today to call on you and other federal agencies like the FDA to immediately do everything in your power to stop leaving children like Caroline behind with regards to COVID. Let's speak to the issue of vaccine uptake for under 5. Parents like me were told under 5 vaccines would be coming in February, then March, then April, etc. I kept asking CDC and FDA leadership, when would my daughter be able to get a COVID vaccine too? Soon, you said. Children are vulnerable and this takes more time. I wonder why, for the most vulnerable, the agencies tasked with keeping my child safe instead allowed delays, which left her more vulnerable and for longer. And while we waited for that under 5's vaccine rollout for Caroline, she and every single other toddler in her class got COVID. This artificially created delay in taking more time for young children's boosters will have the same impact. Kids will get COVID, parents will decide the kids don't need the booster since they just had COVID. Children get left behind on the next variant booster when the new strain crops up and the loop continues. Have we learned nothing from the primary vaccine rollout for children? Delays don't magically increase vaccine uptake. I speak to urge you to create a plan for authorizing bivalent boosters for kids under 12 now based on the same criteria for adults, similar to the way the annual flu vaccines are authorized. If you have legitimate reasons not to do this, we as parents deserve to know. I deserve to know if Caroline will finally be able to go to a Christmas service this year or meet Santa in person. Please do better for Caroline and children who can't assess personal risk and who are too little to wear a mask. Take decisive actions now to bring timelines together. Young children need access to boosters in order to be, as Caroline would say, all done with COVID too. Thank you.
Thank you for your comments. Next, we have Dr. Julie Booth.
Thank you. The last 2.5 years have been a sobering reminder of the discomfort and devastation that infectious diseases can cause in our lives. Despite the relentless work of the medical and scientific communities to develop SARS-CoV-2 vaccines, we have lost over 1,040,000 lives to COVID-19. In addition, over 200,000 U.S. children have lost one or both parents to COVID-19. Gratefully, COVID-19 vaccines have dramatically decreased hospitalization rates and deaths since their implementation. Despite strong vaccine effectiveness and outstanding uptake by persons over 65 years of age, COVID-19 vaccine uptake has been suboptimal, especially among children. From a recent summary of CDC data shared by the American Academy of Pediatrics, 60% of teens 12 and older have received 2 doses of COVID-19 vaccine doses, while only 30% of children 5 to 11 years of age have received 2 doses. Sadly, only 7% of children 6 months to 5 years have received 1 or more doses of COVID-19 vaccine. Even though children have experienced much lower hospitalization and death rates compared to adults, over 1,700 children have died from COVID-19 since the beginning of the pandemic. As you examine the evidence to recommend bivalent COVID-19 boosters for persons 12 years and up, I urge you to consider one of the most important factors contributing to low vaccine uptake, vaccine hesitancy. Unfortunately, vaccine hesitancy is not only impacting COVID-19 vaccines, but also routine childhood vaccines. As evidenced by wastewater surveillance, poliomyelitis has found its way back into the United States and has caused a preventable case of paralysis in an unvaccinated adult in New York. Even though many thought a serious pandemic would diminish anti-vaccine sentiment, the opposite has occurred. Espousing personal liberty and individualism, many have spread information on social media, preying on worried parents, many who are just trying to do the best thing for their child. Beyond polio, we are now faced with the spread of monkeypox. Sadly, the first U.S. death from monkeypox occurred in my county, Harris County. At Texas Children's Hospital, we are again working quickly and diligently to partner with our local and state health departments to ensure we can assist with vaccination of persons at risk or who have been exposed to monkeypox. As a general pediatrician with 27 years of experience and director of the Immunization Project at Texas Children's Hospital, I know that vaccines are the best way to protect persons from contagious diseases. We must do everything we can to eliminate vaccine-preventable diseases in our communities and globally, which includes not only recommending and administering vaccines, but clearly communicating vaccine safety and benefit information to address misinformation and hesitancy. I urge you to give these factors your every consideration today. Thank you.
Thank you for your comment. Next, we have Ms. Katherine Falk.
Hi, I'm Katherine Falk, a parent and vaccine advocate in Oakland, California. I want to again thank the committee for all their work. I've commented before. We're in our third year with this pandemic, and while I'm excited about a new and hopefully better booster, I'm also somewhat trepidatious. Not about any risk from the vaccine itself. I'll be getting it along with my whole family as soon as we can, but about the public reception and willingness to take advantage of it. In Alameda County, where I live, 90.4% of us got one shot, 83.3% got two, but only 56.4% got a booster. This is all ages. Combine this with the lack of real push for mask wearing anymore, and no wonder this season could have been referred to as hot zone summer. We need better communication and clearer messaging from our public officials and the CDC, and for the booster, carefully managed expectations. The other thing I want to bring up is VAERS, because I'm seeing it brought up a lot online. Anti-vaxxers are hard at work as usual, doing their utmost worst to scare people into skipping boosters for themselves and their children, and they are using VAERS as one of their tools. I've started describing VAERS to people as a tip line. I think that's a good analogy, since a tip line is an important part of any law enforcement or public safety system, even if some of the tips themselves are not helpful or even accurate. But I think the VAERS website could use some refreshing, and the communication about what it is and isn't for needs to be clear and reiterated at every level. Thank you.
Thank you for your comment. And our last speaker is Dr. Abraham AlHamad.
Thank you. Good afternoon. My name is Abraham AlHamad. I'm an assistant professor of pharmacology at Texas Diagnostic Health Science Center, JH-OG, School of Pharmacy in Amarillo, Texas. First, I would like to thank the committee and staff for the outstanding effort to put work on this meeting in the past and during this pandemic, ensuring that life-saving vaccines are recommended in a transparent manner to the public. My only comment and concern today that I share with the committee is the rather confusing messaging about booster and a vaccination rate of children below the age of 12, which have been lagging in the uptake as we are heading to a fall winter season, a period of the year. In the past year have been shown to be worse in the Texas Panhandle when it comes to the number of cases, hospitalizations, and deaths. These vaccines are very safe. They still hold on against Omicron variants. They have been quite aggressive on pediatric population here based on the number of COVID-19 pediatric admissions that occurred in the Panhandle. This concern is particularly even more accentuated in rural areas that I have witnessed here at the Texas Panhandle. To give you numbers, we only have yet to reach 50% of the population in the Panhandle fully vaccinated with 2 doses. We have only 20% with 1 booster dose. The Texas Panhandle are historically far worse than the state average when it comes to states of cases, stress healthcare system, and fatalities inherent to the pandemic. It is unlikely due to vaccine shortages. It's in part due to a massive anti-vaccine campaign by various entities that have been very successful in favoring it to population needing the most. If the committee and the CDC can improve the communication and outreach to the public with clear, accessible, and consistent messaging across the board, but also tailor it to a population falling behind vaccination rates, as the vaccine movements have been very successful in seeing doubt and fears within this population, it would be clearly appreciated. Thank you.
Thank you very much for your comments. And with that, we have completed our public comment session. I want to thank our public comment speakers for your willingness to engage in the deliberations today. Also would like to thank those who provided written comments as well. Now, what I would like to do is take a short break and just confirm that we will get our next speakers on the line. So why don't we take a, let me ask Stephanie or Dr. Wharton or Dr. McNeil, 5-10 minutes?
That's fine, Dr. Lee, either one.
Okay. Why don't we take 5 minutes if that's okay with everybody? So actually let's meet at 50 minutes after the hour, 5-0. So we'll see you back in about 8 minutes. Thank you, everybody.
Thank you, Dr. Lee.